Good evening and welcome to my webinar tonight. Tooth Structure, Nature's Best Restorative Material, Use It, Don't Lose It. This is Dr. Richard Young. I'm coming to you from Riverside, California. It's 85 degrees today. Wonderful day here. We're about an hour out of Los Angeles. We have quite an international group I see with Mexico, Kuwait, Cairo, Santa Lucia, Qatar, Australia, Philippines, India, Indonesia, Lithuania, United Kingdom, Saudi Arabia, United States and Canada represented. So welcome to all of you. Some of you, it's late at night the next day, and I hope you enjoy our seminar tonight. Let's get started. I'm Dr. Richard Young. As I said, I'm assistant professor at Loma Linda University School of Dentistry. I just guest lecture there and co-direct a program. I've been 30 years using dental photography in my practice, an emphasis on aesthetics and tooth-conserving dentistry, and I practice with my wife. I co-direct this program. It's unusual. We teach real-world aesthetics to the juniors by people who are experts in the field, and it's the purest form of giving back to students. It's all done as free, and it's pretty awesome to have all these friends and colleagues and mentors come in and present to these students. I can't give a lecture without talking about photography. I'm mostly known for photography lecturing throughout North America, Canada. I have 2 camera recommendations. In this lecture, one of the most important things is learning to use a camera, because this is how you present these concepts to your patients and help them understand and see what you're doing. So I recommend Nikon or Canon, particularly these 2, because of their ability to set the U2, U1, C1, C2 settings, which automates the settings for your camera. And so you can set these up with a really nice lens. You can use a ring flash. This is the Met's, my particular favorite. If you're going with ring, you'll see posterior shots today that are all shot with that ring flash. I'm not fond of rings, but it does work very well. What's in my office, actually, I keep a quiver. I have my anterior set up on the left with the twin flashes, which of course is for shade work and any high-end anterior photography. And then I'll use the 7D with a ring flash for the posterior and point and shoot as needed. Advanced adhesive, minimally invasive dentistry, my 30-year clinical perspective. Let's look at the lecture outline. We're going to talk about a historical journey in adhesion, supportive key research, immediate dent and sealing, deep margin elevation, cementation case studies, indirect Emax, and Katana. So let's get started. Curare. 1986, the summer, Ray Bertolotti, 5th quarter seminars. We were looking for a way to write trips off to Hawaii, and we found this seminar, and my wife and I decided to attend. She was fresh out of school. I'd been out 1 year. And we were introduced to a company that day called Curare. It changed our life in dentistry forever. We continued to attend 5th quarter seminars every summer, because we would write our trips off to go windsurfing at a family property. And so we would take 1 day off and always go to Ray's seminars. And so we had a historical journey in the world of adhesion that's extended through in a close friendship with Ray through today. Who was Curare and the company I heard about? Many of you have not heard of them possibly. It's Kirishiki Rayon Company. They were the first product rayon fiber in the 20s. So the name became Curare. Those who know NASCAR racing know that it keeps the tires and the hoods on during crashes, and they're in the NASCAR Hall of Fame. Other products many of you are aware of, the Grand Canyon Skywalk, 71 fully loaded Boeing 747s, 71 million pounds. They create the plastics for that. Over here, those of you who golf, play basketball, Clarino, synthetic leather products. Many of these things you see and you know, and so they're an incredibly great company, but a little smaller known when it comes to their marketing. And so they certainly have applied the same principles of high quality to bonding. 3M is one of their customers. So that kind of gives you a feel for who this company actually is. So we met Dr. Ray Bertolotti, my first mentor, in 1986, and I heard of a Dr. Fusuyama, who was the father of Total Etch. And that really changed. We came from a background where we were protecting the dentin, and that lecture influenced my entire career and where I am today with adhesion and bonding. What we learned that day was that adhesion, with the less need for tooth reduction, is highly desirable shift away from tooth preparation for mechanical retention. I had learned gold very well at Loma Linda University. It was kind of a bastion of gold work, and had joined Tucker Study Clubs immediately out, and I quickly went, wait a minute, if we take and change the preps and round them out, possibly causing less stress, we can bond these in with Panavia in its very early years when it was first released. And so I kind of geared towards that and moved that direction with gold. And so we would bond our gold back in those days, tin plated, air abraded, and then bond it with Panavia. And so this evolved into where we are today. And so I have used Curari's product from the very beginning, from hearing Ray's lecture through today. It's always the bond I've used. So I have a 32-year history. Hence, Curari is covering my honorarium today. I want to disclose that. But it has not changed the way I work, and it wouldn't, because I've always been with this product and for many, many, many years. So let's talk about a few things. What does cosmetic aesthetics, CERAC, holistic general, current dentistry all depend on? They all depend on adhesion. There's some terms out there that you've heard, and these are, what do you call an adhesive dentist? You've heard about bondodontists maybe, or biomimetic dentists. In Europe, the bioemulation group, or bioemulative dentists, and tooth-conserving dentists. Well, I like to kind of take two of my very close friends in conversations with them, where Dan Fisher said, I call it a caring dentist, and David Clark said, I call it modern dentistry. Well, I just love it, and I put both of those together, and what do we have? We have a caring dentist doing modern dentistry, and that's where we are today, because the techniques that you're going to learn come under all those terms, but in reality, it's modern dentistry. Who are the current leaders that followed Dr. Fusuyama's footsteps, and his book, sort of the Bible in original adhesive bonding systems? Certainly Ray Bertolotti back in the 80s started on, and then Dr. Tagami was Dr. Fusuyama's protege. You had bioemulation in the early 2000s with Pascal Magnier and his brother Michel as a lab tech contributing a lot to those techniques. You had in 2010 biomimetic group Simone Della Peri, and of course Dr. David Alleman, who did something unusual in that he took 165 articles, spent about 10 years going through them just line by line, word by word, and basically correlating the research on clinical concepts. And so for many of us, we'd heard these articles over those years quoted by Ray in his literature reviews each summer. But David kind of put it together and came up with the concept of the science supports what we were clinically seeing all these years. And so for me, it didn't change so much what I did, but it just put an interesting perspective. And so Dr. Alleman is certainly known for his passion to do all and work with that research. Graham Milicic must be mentioned as a phenomenal lecturer, if you get to hear him, on structural dynamics of teeth. And a must hear. He has a lot of information on his website, and I'd highly advise you going there and looking at some of his research as well, out of New Zealand. No discussion is complete without Dan Fisher and Ultradent Products, the contributions that he has made, of course, to adhesive dentistry, conservative dentistry as well. What did we learn that day in August of 1986? That it was better to etch dentin, total etch, that you should layer your composites in small amounts, that you should not rush the bonding steps or composite placements. We learned the post-op sensitivity after our composites was history if we did all this correctly. And then a bit later, the high-intensity lights came out. We learned that they really stressed the bonds, and we needed to handle that differently, and et cetera, et cetera, et cetera. But this was the whole early original concepts of not stressing our bonds. And so what I really learned was that high-quality bonding products mattered. You did not want to stress the bond. And so could any of this work? Well, let's take a look. These are the products that I've used over the years, started with New Bond, went on to Photobond, Liner 2V, Panavia F, and now currently Clearfill SE, SE Bond, and the Dual Cure Activator. And so my history, I still keep this bond in the fridge. This has never changed for me. But there's also a couple others that I'd always play with. And these are kind of the gold standard bonds in dentistry today. We also have Optibond FL, and we have Ultradent Peak, and you could certainly throw Prelude into the fray as an Optibond type product. Optibond FL was really the other bond that I played with and always would goof around with. It was a great bond, and it is a gold standard bond today as well, and used by many of the other bioemulative dentists as well. So what we were able to do is we were able to take a piece of structure like this, and if we understood bonding and its principles and its strengths, we could take that piece, cleanse and sterilize that pulpal exposure, and we could put that back because it was like a piece of glass. And so we would use, in this case, Clearfill SE Protect with the dual cure activator and a very selective etch, a good gel etch, and we would take the piece and put it back. No composite whatsoever, bond only, otherwise your interface will not fit. And so we can look at this in 2011 from 2009 and move on through the process. And now we have ortho bracketing, and that might make some of you nervous. But the orthodontist just popped this bracket off like they do every other bracket. And so in 2015, this is your tooth, and that's what it looks like. So we know the bonds hold even under those kinds of situations. And I did these for years. It's just that I didn't photograph cases back until recently because I never had an intention to lecture on this. And so I have a lot of neat cases, unfortunately. Didn't photograph them. Just photographed my new patient exams so that I could present dentistry. David Clark, his BioClear Matrix system, there's some really neat things you can do with it. He's a very good friend and has some awesome concepts as well. And so you can take a tooth like this that otherwise might be an implant extraction. The patient wants to preserve it. He's got an old adaptic filling right here and says, look, can't we save this? And so we can take our technology that we're going to present today, we can put in a BioClear Matrix, wedge it well, and do immediate dent and sealing on that. And then I'll use heated composite too, and I'll use it in a two-stage injection mold essentially, and I'm going to inject APX first for my dentin back layer, and then I'm going to come in and inject right on top of it with an enamel layer and bulk cure from both sides and a lower stress C factor on this type of restoration. I'm going to basically get that restoration. And I know that that's going to last for many, 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 many years because we've not stressed the bond, we've done things correctly. Back in the day, we'd see these teeth with the cracks. They were asymptomatic, and so we just basically, it was called a generic concept to me. David Alleman and Dan Clementino with Curari came up with biomimetic stabilization technique. To me, it was a composite with some rib-on reinforcement. We go in and we put a little bit of rib on. We had done our immediate dent and sealing and then put our composite in and basically built up a generic everyday composite, as you see here, and we'd see these things last for years. So we get on to other restorations that needed to be done, and these are usually people on a budget, but we'd also see these last for years done correctly. Monolithic zirconia, when it came out, we thought about, hey, let's use the wings. We know we can bond to zirconia, and so why not use it in a Maryland Bridge situation? So in 2010, I tried this one for the fun of it, and basically put that on, sandblasting Panavia 2.0, and there it is in 6 years post-op. And I actually saw this patient today and have an even better photograph that I took this afternoon of that restoration, and it looks wonderful, and good luck getting that off. And so we can bond zirconia to a flat surface like that. No prep done on that whatsoever. Let's look at the supportive key research for all of what we're going to talk about. I want to talk about three different areas. Immediate dent and sealing, first talked about in 92, then in 2003, and in 2005 by Pashley, Tagame, and Monnier. Now, in Pashley's article in 92, we all started putting on bond on our post-preps, and then we clean the margin gently and take our impressions and temporize and come back. And what it allowed us to do, we had sealed the dentin so we could seed our crowns with zinc phosphate even and not have post-op sensitivity in our full coverage crowns. And so that was the early years for me with immediate dent and sealing. And then it advanced. And an article and a research that I want to talk about is the advantages of immediate dent and sealing are well known, that we can increase bond strengths 200 to 400%, conserve maximum amount of tooth structure, protect the dentin, enable deep margin elevations, increase onlay bonds by 264% compared to traditional methods. Soft tissue reacts better, less or no bleeding, etc. It seals out bacteria. And so when we look at one paper in particular that I really like by Dr. Takami, you'll see in this paper these materials. They use Clearfill SE bond or single bond, Protect Liner F, Clearfill APX, Estina for the indirect, and Panavia. And what they did is they sectioned dentin, resin coated it, temporized it for a day in water, and then put an indirect bond to it. And so what this looks like in a graphic form, so they cut the tooth off, and in this case, this was a traditional method with delayed dentin sealing, meaning they didn't seal this dentin here. They put a temporary on it, soaked it in the water, then they took the temporary off, took their indirect restoration, put in the Panavia, and bonded it to the dentin. They had a bond strength of 10.3 megapascals. and that's what it took to pull that off. Now, in the highest bond strength, what they did is they did immediate dent and sealing. They put down clear fill SE bond, which is what we do today. They put down the Protect Liner F as a layer on top of the SE bond. Then they temporized, soaked it in the water, took the temp off, cleaned, and cemented the restoration with Panavia and got a 27.2 megapascal bond strength, a great increase. And so this is the control group of Panavia, just bonding a restoration on without any pre-dent and sealing, 70% increase when you did just SE bond, put on the temp, soaked it. But when you put SE bond with the flowable, soaked it over in the temporary overnight for 24 hours, and then bonded the restoration on with Panavia, our bond strength went up to 27.2. That's a 264% increase from the 10.3 to the 27.2. Now, if you were using a single bond with Panavia only, like the SE bond, you had a bond strength of 10.5, about the same as Panavia F control group. But if you did single bond and added that flowable layer, you went up to 20.8. Now, this was the SE bond with APX and single bond. This is just a class 2 composite. Of course, it came apart off the dent at 42 and 32 respectively. So in the chart, what this looks like is your control group, 10.3 bond strength. The cement denim interface failure, when they pulled it, 100% of the time, that's where it came apart. When you put SE bond with Panavia F, 17.7, 0% cement and dent interface, 80% between the resin coating and the cement, and then 25% at the resin cement. When you went up to SE bond flowable with Panavia, there's your 27.7, again, 0 at the dent interface. And this is the critical area where you don't want failure. That's your dental margin. When you use single bond with Panavia, 40% failed at that position. Single bond with flowable and Panavia, 0%. And so this is really why we're really looking at this research article for immediate dent and sealing with a bond and a flowable composite. These were interfaces of the resin. The other next research article that I want to touch bases on is the C-factor and layering techniques, and we're all quite familiar with C-factor these days. The first research came out in 1987. I remember in the early years, Ray would have us layering horizontally, and then we played around with oblique layering and some of the other systems, and then kind of the research came out, and Ray goes, you know, hey, I'd probably go back to horizontal layering again. And some of us just kind of stayed with horizontal layering, including myself, during that whole time. I never went into oblique layering. And I guess I was just lucky, because we'll see in a moment that that's kind of the way to go. So when we look at C factors, we know that the class 1s and the class 2s are our highest stress C factors. And I'm not going to spend a lot of time explaining C-factor because there's so many articles that you can look and deeper into this. But the highest C-factor is the most critical area, and that's your class 1s. You have the most ratio of bonded walls that can give you problems. But what I really want to look at is how the influence of C-factor and layering on microtensile bond strengths to dentin. So when you have a bulk fill and you bulk fill a product with you're going to go one layer of 4 millimeters of material, you'll get a bulk fill MPa of around 11 in this particular research article. When they went to oblique layering, 2 layers at 2 millimeters each, 17.6. When they did it 4 layers, 1 millimeter increments, they went up to 20. Vertical, 15, 7, 19. But when they did horizontal layering, 2 millimeters, they were at 16, about the same. But when they did 4 layers, 1 millimeter each, we had a bond strength of 31. That's a huge jump. Now, in today, oblique is the most common layering system out there. And so you have an 80% increase in bond strength from here to here if you just simply horizontally layer in 4 layers, 1 millimeter each. So for a lot of us who want to create the highest quality restoration, I've always layered in anywhere from 1 to 2 millimeters, but try to keep it at 1 millimeter layering to create the least amount of stress. So bulk fill down here, you know, it's kind of a whole other issue on bulk fill. I'm not a big proponent of bulk fill, but so it's not an area that I really focus on a lot, but we'll touch on that in a moment. Article number 3 is a research review that was done by Van Meerbeek out of Belgium, one of the most comprehensive, and this is quoted by a lot of people. And this is where the gold standard bonds come in many of the lectures today. They reviewed 1,700 laboratory adhesive bond tests, 1,000 included in the analysis. Clearfill SE bond was the most tested adhesive in the literature review of the 280 bonds. They reviewed 15 years of clinical class 5 research studies, updated the clinical review, analyzed for 63 years of the clinical studies. And what the conclusion was that he found was that altogether, when bonding to both enamel and dentin, selective etching of enamel followed by the application of the two-step self-etch adhesive to both enamel and dentin currently appears to be the best choice to effectively and durably bond to tooth structure. So when we look at that research, glass ionomer, of course, had the lowest failure, the best success on fresh-cut dentin. But the next strongest was your two-step self-etch mild acidity. That happens to be SE Protect and SE Bond. Next was your three-step etch, prime, and rinse system, which would be Optibond FL, Peak Ultradent, Prelude, Danville, these here. So when you look, and then your one-step self-etch mild acidity, you've got Clearfill S3 right here. So if you look at the 5 gold standards, this is kind of where they come from right here. And so when you hear that term, a lot of people talk about the gold standard bonds today, it's right here. Ironically, I was just lucky. I happened to pick Curare as the bond I stuck with for 32 years, and I played around with both Peak and Optibond FL and Prelude over those years as well. And so it was just sheer luck that I never veered from any of the other bonds and stay right there. So now let's talk about immediate dentin sealing. We have to touch bases very quickly on the biobase and why is it so important and how do you do it. Well, when you look at a tooth, the physical properties of teeth, they're naturally functionally graded. And look at Dr. Milisic's research and discussions to understand more about this. But you have modulus of elasticity of teeth and tensile strength of teeth. Tensile is the pulling apart. Modulus is the flexing. And dentin has many different moduluses from the DEJ, superficial, mid, and pulpal dentin. And so you see these different numbers and then enamel. And what we're really trying to do in our material selection is, do we mimic teeth? Do we duplicate tooth structure? No, that's absolutely impossible. It's just a phenomenal structure. And to try to create it and functionally grade materials to act exactly like it, any lab tech will tell you they can get close, but they can't do it when they're coming to the true qualities and appearances of tooth. But we want to try to get close when we pick our materials. And so when we look, this is just, again, sort of pure luck as all this research starts coming together and some of the concepts that are being taught. But I always use Majesty Flow. I liked the product when it came out. I did use StarFlow some, but I like the way Majesty Flow works. So that's what I used since the day it came out. Clearfill APX, been using that for 20 years in the dentin layer. It had a modulus of elasticity that got closer to deep dentin or mimicked the dentin down where we put it. Same with the flowable up here. And then we would use one of these bonds. So your APX at 16.7 was close to the cement-enamel junction, that level of dentin. This is your flowable down here at 11 gigapascals. So we're trying to pick materials that sort of have the modulus of elasticity of the area we're working. So these just happen to be the materials that I use personally, that I've used for years, and they just apply to the immediate dentin sealing concept. I have a bias in myself with this Clearfill SE Protect now over the SE Bond. The reason being is it's an antimicrobial cavity cleansing. In the primer, it has a deactivation of the MMP enzymes. And so that's one of the causes of dentin bond degradation. So many of you have heard about MMP deactivation. Well, we don't have to do this separate step with this product. In the Etch Prime, it has those properties. It also has a unique encapsulated fluoride that creates a superdentin layer. So if moisture hits at, say, a margin, these encapsulated fluorides are released. And so for these reasons, right here, I like the SE Protect. And the other one is in their clinical research. It shows that Clearfill SE Bond, after 24 hours, 21.3, 17.9. So Protect is a little bit lower, but after 1 year, SE went down to 13.8 in the bond strength, and actually SE Protect went up to 18.6. So when you look at this, you don't have any the dentinal bond degradation, and so that's kind of important to me. You want that bond to not degrade. 5-year cervical lesion clinical studies, SE Protect had 100% success. And so for these reasons, I've been using a lot of SE Protect lately and really enjoying it. An extremely important statement in dentistry. Adhesive dentistry could be expressed as a simple relationship between bonds and stress. If the bonds can withstand the stress, the restorative technique will be successful. Dr. Unterbrink in 1999. This really sums up to me so much of what we do in modern dentistry today. We just do not want to stress our initial bonds. So let's look at immediate dent and sealing. We're going to look at it in two different places here. Right now, we're going to look at it in the form of an indirect restoration. We're going to use SE Bond or Protect Bond as our bond, and we're going to use Majesty Flow as our flowable. And so in this video, let's watch what we do. So we freshly cut our restoration, and we're ready to move on to preparation. And so we're going to do immediate dent and sealing. The first thing we're going to do is we're going to come in and scrub our etch prime on all the dent. Now the enamel is not critical here because we're going to bond to that enamel later. And so we really are focusing on the dent. It's going to get on the enamel, and that's okay. We scrub that in for 20 seconds, and then we air it thin and get rid of that, thinning it out a little bit. So after the gentle airing of the etch prime, we're going to come in with the bond itself. And we're going to scrub this bond into the dentin for 20 seconds as well. And we're going to really work this in to the dentin. So we'll watch as that happens. You would do the exact same thing with your other systems. Scrubbing this dentin in and getting a good coating there. And I'll soak up the areas to make sure it's not pooled down by the base of that matrix. So now we're going to come in, and you could gently air it to thin it if you wanted, or you can gently take your micro brush and soak up any pooling. So in this case, I show airing. We'll now come in and cure this, and we've done our basic bond. The initial bond layer has gone down. Now the next layer is what's the most critical in this whole process. After we've cured for 20 seconds, we're now going to come in and we're going to place our flowable. And this is where I really like the Majesty Flow, as you'll see when we finish this curing, because this is a real-time video. So now we're going to come in this position. Where's the most critical place in this restoration? Right at the margin of the interface of that matrix. So whether it's a class 2 or a deep margin elevation, right there is where it's critical. So I'm going to put a little bit in. I'm going to work it gently with an Explorer or a Perio probe, making sure I've sealed that off, and that's the first thing I'm going to cure. So I'm going to come in and cure that in a non-stress 20-second cure, because to me, there's no more critical place in this whole restorative process than right there. Now, once that's cured, I'm then going to come in and place the rest of the flowable. So now we'll come in, and what I like about Majesty Flow is when you put it down, it kind of stays put. I kind of talk, it's like a little puppy dog. It'll follow you around where you want to go. And so I will take a Perio probe, and I want to keep this first layer, I want to keep it no greater than 1 millimeter. This is critical to keep a stress-free environment. So you can use a Perio probe with a mark. Jeff Brusha has an instrument out that I like. It's got a plugger on. It's by Brasseler, and it has the millimeter markings as well. And Brasseler sells that composite instrument. So we're working the flowable around onto all the dentin, covering all of the dentin. Now you could add a little more to maybe block out a light undercut, or just give a nice flow to your preparation if you want to do so. You could add another millimeter layer or just a little bit, wherever you might feel is necessary. But initially, this first 1 millimeter layer is our immediate dent and saline layer. on top of our bond, and now we light cure that. And now I have immediately dentin sealed or done IDS on this restoration. It's that simple. And if you keep that in mind, what we just did, you really learned immediate dentin sealing. So we've cured that. So we're going to move on. So we've now done the immediate dentin sealing. This is what it looks like. It's a nice radio opaque product. You can see the flowable here and shows up very nice on x-ray. So now let's talk about deep margin elevation. This is a kind of a hot topic with people, but if we do our steps accurately and carefully, the concept behind this is if we trust our bonds, why not bring the margin up to a height? For some, it's easier to bring a margin up to a workable height than do careful bonding around a matrix than to possibly get a deep impression and an accurate cementation and cleanup. So what we do is we basically now, we've done our immediate dentin sealing, we've locked the flowable down there at the bottom of the matrix, so we're simply going to come in with APX in this case, because that's the material that I like for this. It flows so nicely, yet it has a high compressive strength to support enamel or your restoration on top, your simulation of that. And so we're just, it goes where you want it to go when you pack it. And so we push that into position. Again, you could do it in your 1 or 2 millimeter increments here. The bond has had some time to stabilize, so we're probably not going to stress that because it's probably a couple minutes before we get to this. We're going to work that into that corner. We're just going to bring this bond to where we want it. And that's really deep margin elevation. We put a good composite to the level that we want, and we cure that. And so I'm going to skip past the curing, and we're going to move on and show you some real cases. So the idea behind deep margin elevation is to raise the height required to effortlessly have access to the margin with a rubber dam placed and still maintain the correct height of contour and proximal emergence profile for the contact and restoration. So I basically put this where I can work nicely. So when we look at an endo tooth, deep margin elevation right here, we probably could have gotten a margin prepped on that, but I decided to do this with a matrix band. So we have that beautifully sealed with the matrix. So we'll go in and we'll do the immediate dentin sealing that you saw. We'll put our APX in, and when we get done, we've brought that APX up to the level that we want it. Now we don't need to worry about closing a contact. That's not important at all. In fact, we don't want that. And now we go in and we use a heated composite many times. A lot of what you saw, I will use an Adent. There's numbers of composite heaters out there. Dr. Clark has a great one. Adent has a great one. I use them both, and always one in each operatory. So we can use a heated composite if manipulation makes it a little easier. And so we've raised that margin. Now we've prepped out this restoration for that onlay. We've preserved a great amount of tooth structure here, but look at the beauty of this. I can pop a rubber dam on, I can take an impression without cord, and we can go in and lock on temporary, and then there's the final restoration seated. If you look at this as a situation, a hopeless tooth, what are we going to do down here? Prep this, I'd have nothing left. Well, let's do sort of a modified deep margin elevation in a sense. We can get a matrix on that. We know we can wedge that. We can seal that off beautifully, even without a rubber dam. There's no moisture going to get in there. We basically do a deep margin elevation, except we're not going to prep it out. And so there's the finished restoration for this patient. On x-ray, that's where we started. That's where we finished. Now, does this work and does it last? Well, we'll show you an x-ray. This is an MO31 onlay placed in 2002 with SE bond and StarFlow SRO, deep margin elevation, and Panavia cement. I think this was actually done before even the term deep margin elevation came about. I did my first deep margin elevation in 1988 with amalgam on a gold onlay, and the amalgam was bonded with Panavia. So we've been doing this for years because we trusted our bonds. That is the interface of the restoration to the APX right here, and the SRO is below there. So is this holding up? Absolutely. And that's what a deep margin elevation would look like on x-ray. Right, there's the interface of the restoration that was bonded on top with Panavia. Let's look at class 2s. We're going to look at Clearfill SE Protect, SE Bond, 6th generation products. For my class 2s, everything is the same. I'll use either of these bonds. Right now it's SE Protect. I will always use Majesty Flow, generally A1, A2. and always clear fill APX, usually A2. That's my dentin layer. What I put on top can be whatever you like. It might be matte. It often is Herculite. It can be heliomolar. It can be Vital Essence. There's all kinds. I kind of play around with that enamel layer because that's my fun carving, sculpting layer. But these two never change. And this hasn't changed for 20 years since it came out in the early 90s for me. Actually, more than that, I guess, whenever this came out. So there we have it. So we're going to speed this up, and we're going to do this fast in a class 2, and you're going to see every step of the immediate dent sealing, including the selective etch that was talked about in the research. So here's our selective etch. We're coming in with that. We're going to let that sit. We're going to rinse that off. Now we're coming in with the etch prime, and we're going to scrub that in. Did I pause that? Let's get it going. Something's not playing on this video. Here we come. We've done an etch. We're drying this. We've done an etch prime. Now we're going to come in with the bond. We're going to scrub our bond in, and you're going to notice I soak up some of the bond with a 2x2. So there's a 2x2. I'm going to go in and make sure it's not pooled. Then I'm going to come in and make sure it's smooth. I'll cure that. Now I'm going to come in with the flowable. The first layer is going to be at the matrix margin right there. We're going to put that in. We're going to cure that. You'll see quick. Now we're going to come in and add the rest of the flowable covering all the dentin. Now we're going to cure that. We're going to come in with the next layer, put in a little more flowable in this case, another millimeter. Now we're coming in with APX, and that's our dentin layer. And now I'll build, after that's cured, I can build my marginal ridge, a little APX there if I want. I did this one all the way with APX and sculpted out. And this is just a day-to-day generic class 2 restoration done in high speed. And so you can see that nothing really changed in the immediate dent sealing whatsoever. It's just this final layer that you might choose some other material to sculpt and to play with and to use. I just happen to use APX here. And we'll go in and remove the matrix, polish it out, clean it up, clean the margins. And now we have a generic day-to-day class 2 composite restoration in a fairly fast amount of time. And we're just putting in a little bit of anatomy, and we'll use a finishing burr there, and we'll polish it out, sculpt the ridge, and you'll see the finished product. And so there's our generic finished class 2 with immediate dent sealing. But ironically, I've been doing them that way since the early 90s, back even to when we were using Bisfill 2B with guided shrinkage back in the early 90s, for those who remember that day and that far back. And so I guess we were really doing all of this high reduced stress type of procedures. So for some, there's a new dawn arising. You've learned about immediate dent sealing and how important it is. So let's look at the cementation and case studies for indirect Emax, and we're going to talk about Katana zirconia. Some of the must-haves in my office, I need an air brader. I have one of these at each chair. I have a micro cab in the lab where I can air braid the zirconia, and then I like to have a transilluminator so I can look at cracks and teeth. And certainly might have some fissurotomy burrs around. You could have more advanced air abrasion systems. There's a number of them out there. There's one by Danville. There's Crystal Mark. There's a number of great products. Dr. Rainey makes one. So those are your more advanced adhesion cutting devices for these. We aren't going to talk about that today. But the minimal for me is what you see there in the air abrasion in the lab and then chair side. We're then going to choose some cements. Now, for myself, basically about 28 to 29 years when Panavia came out, I always used Panavia to cement my indirect restorations. It was kind of a pain to clean up in the early years, but I got used to doing it. And so I stayed with this product because it just worked, and I saw that it lasted for years. And so V5 is the latest generation of it. Some of you may have F2.0. We're also going to talk about Katana zirconia. It's a gradiated puck, so your labs can position the restoration in here and get a much more lifelike restoration. It's kind of, in strength, it's kind of halfway between Emex and pure zirconia. And so look into this product. It's a really, really neat product and really wonderful to work with in the posterior region. And they're doing anteriors. It comes in ultra translucent, super translucent. So the ultra translucent, the UT, they're even milling veneers out of this product. It's pretty amazing with the labs. So let's take a look at a tooth. This tooth was on Tuesday of this week. Patient split this tooth with his number 18, bit down on something and split it in half. After that happened, I wasn't too happy, and I looked at this tooth and I said, you know, I see peripheral rim fractures right here. We really need to disassemble this. It's asymptomatic. And when we did, we saw this fracture going down, this peripheral rim fracture right here. You can see it extending, starting to extend into the dentin. And when you transilluminate it, you can see it running right down here and starting across the dentin. So we're going to go in, and every tooth is the same. We disassemble, we look at the cracks, we evaluate. I want a minimum of 2 millimeters of thickness of tooth structure. Otherwise, I'm going to onlay it. So once I've assessed, I start making my depth cuts. We're using a Brasseler 1.5 millimeter depth cut burr here, and that way I can reduce under rubber dam and note pretty accurately. I like this round end burr. We have the number later on. I'll go in and take away my depth cuts and basically bring down the height for my preparation. In this case, we're going to cover the whole top of this tooth. We have to put a dome back on it because you can see the crack running right there. We're now going to go in. We've basically done the rough prep, and we've got our crack here, and we have a dentin tension fracture starting here, but it hasn't gone all the way through out to here. So I did reduce this cusp a little lower to get this a little more flat, and I want to bring it to a position where it's not in tension but in compression. And so there we're ready to go. I'm going to take Rib-On. There's going to be a little dollop. I'm going to do my immediate dentin sealing. Then I'm going to come in with a little piece of Rib-On, and I'm going to take a dollop of APX, put it down, and put my Rib-On into place, and you'll see it in the next slide. We have the Rib-On coming in like this. There's under there is a tiny dollop of APX, which allows me to position the Rib-On where I want it, get it exactly as I like it. I've compressed all of that APX out so that it's virtually thin or it's been wiped away. And then I come in with the micro brush with the Bond and I soak that Rib-On, and it'll look exactly like this area right here. So we put a piece of Rib-On across there. And then we cover this with our immediate dentins, sealing the flowable. And so you can see we put the flowable on and it's smooth and covering all of the dentin. Now, there's been a slight change in the way I approach this prep. That's used to be the finished prep. But after hearing Graham Milicic speak a year ago, I kind of started re-looking at the analysis of these. And this is a tooth that I do not want under tension. So what I'm going to do is I'm going to take one extra little step. And I'm first going to go in and use liquid lens. I need to get away the inhibition layer on the composite, so I'll put in that. This can be done anytime after you place that immediate dentin sealing, because your impression will be affected by it if you're scanning. Probably not as critical, but we'll put liquid lens on. It's basically glycerin. We'll cure through that to get rid of the inhibition layer in the composite. And now we have the finished restoration. And you can see in this photograph that I've actually gone in now and I've put a slight, should we call it a chamfer, all the way around this restoration. I'm still in enamel. I haven't reduced a whole lot differently, but I've kind of gripped or come over top of that tooth. So that tooth is done, all prepped under rubber dam. What's the key here? I did not have to deep margin elevate. My rubber dam will expose this tooth for cementation. It's a perfect environment, no cord required. We take the impression, we take our dam off, check inclusion. I did a little extra reduction here under the rubber dam because I knew this is an area I wanted to have plenty of strength. And we're about right here. So it's hard to tell in these photographs, but we're right at about 1.25 millimeters here and 1 millimeter there. And zirconia, be safe and keep it at 1 millimeter. All right, and then this is the final preparation. All the margins are exposed, no cord required. We take our impression of this. We're going to come in and temporize. We're going to Vaseline. If you're going to scan, you can scan and go to your milling machine. If you're sending to a lab, we'll Vaseline. We've taken the impression or the scan. Now we're going to Vaseline it. If we're sending them home, we're going to use the Cobite tray with a VPS in there that we took before we started prepping. We're going to fill that with Luxatemp or any material of your choice, Integrity, all kinds of things. and we have the patient bite down, and we've made our temporary. We'll come in and shoot our photographs for the lab. That's our restoration. All of this wonderful enamel is preserved. We've kept put a new dome on the tooth. We've basically kept the siding on that tooth, and its strength is there. And I don't have time to go into that detail, but we are now, the restoration is temped. The patient goes home, and this was on Tuesday afternoon. Occlusion is dead on with that temporary system. We didn't touch a thing. Now, we're going to cement this, and how are we going to do that? Let's take one more look at one restoration. Again, we're going to take the amalgam out. We're going to assess. We're going to reduce. And that's the Brasseler 1.5 depth limiting burr. We're evaluating, removing all decay here. Now we're going to come in and we're going to use this 849.016. I really like it because I can round all my internals out in here. I don't want any tension on this tooth. I can keep these areas. There's our slight chamfer all the way around, and that's why I like this diamond. It can do that nicely. We've come in an immediate dent and sealed. And now we've taken the impression, temp that, and it's ready to cement the restoration. Panavia V5. It's a mean-free, dual-cure, color-stable, fluoride-releasing, natural fluorescence, no post-op color change. It comes in these shades. It's stable after 4 weeks. There's no color change, and that's important in an aesthetic zone. The primer, the ceramic primer contains MDP and silane monomers, no water. MDP is used to activate the silane. It will bond to lithium, Emax, zirconia, Bruxer, silica-based ceramics like veneers, metals, and composites. A wonderful primer that has your silane and your MDP monomer in it. We don't have time to talk about MDP monomers, but certainly Curare is known for their MDP monomer. The combination, the new adhesive, is that you have the MDP monomer in the adhesive as well. So it's in the primer for the metal or the restoration, and it's also in the adhesive for the tooth. It's an adhesive that meets right up with Clearfield SE bond in its strengths. So your tensile bond strengths of the LightCure SE bond and the Panavia V5 is self-cure resin cement with a Denton bond equal to a gold standard LightCure bonding agent. So it's a wonderful primer. Let's treat, and we're going to do Emax. We have our Emax restoration. We've tried it in. We're going to hydrofluoric acid etch the restoration after try-in for 5% for 20 seconds to freshen that surface. If it's zirconia, we're going to take it to the lab. We're going to air abrade with 50 micron silica in the lab. And then if you want to clean an ultrasonic, you could clean if you don't have that. Some of you might use IvoClean if you don't have the air abrasion, but for me, having the air abrasion is so much quicker and easier. So we air abrade zirconia, we hydrofluoric acid etch Emax. We don't air abrade Emax. We clean after the hydrofluoric acid on the Emax with phosphoric acid for 5 seconds. We now put the ceramic primer on the restoration, air it dry. We rubber dam because it's easy. Now we surface and clean this. You can etch it and air abrade it. You'll see later. We do both in my practice. We apply the Panavia primer to the restoration for 20 seconds. Air it dry. We fill the restoration with the cement. The MDP primer, the monomer is in both the primer for the tooth and the primer for the restoration. It's not in the cement. So now we fill this. We place it on the restoration. We press it down with a wood stick, and some might use seating devices, and I hold that for 1 minute. Now, during that time, I clean up with a brush while I'm holding it down firmly. Some of you might decide to do a tack cure and clean up the excess that way, but to me, that's even harder, although it's easy to do with this. You just have to get the timing right. But personally, I like to go in and clean it pre. But this is a tack cure. If you tack cure correctly, it'll peel away. So we clean this up because it dual cures for that first minute. And if I allow it to dual cure for that first minute, I will get the highest bond strength of that material and the least stress to the whole system. Then I go in and I hit it with a curing light after that and tack cure and clean it up. This is not necessary when you clean up with a brush, but if you don't, then you can clean up with the margins and disc it. And there's our finished cemented and seated restoration in Emax. Now, Let's go back to a cementation of zirconia. Here we have the zirconia restoration. We have the immediate, this was the case above, the last case we just looked at. We have the immediate dent and sealing. They come back, we pop a rubber dam on. Most of the time they don't need anesthesia. We have a coating on the dentin, so the dentin's sealed and protected. I take my air abrader and I just make a quick poof across that surface to clean it. You don't want to blast because depending how thick your immediate dent and sealing base is, you don't want to blast away your flowable that's there. So we just do a very light clean. I use the 28 micron silica with their fine tip on the Danville air abrader, and it makes a very nice chair side. And so we're going to take the restoration, we're going to air abrade it in the lab, as you see here, and we're going to prime it, chair side. Now we're going to come in and air abrade and clean this restoration quickly. We're going to then come in and acid etch it. I go ahead and etch. Remember, we're etching the enamel. And this is all covered, all your dentin's covered, so we're etching the whole restoration because you're etching basically the lightly air abraded composite and the enamel around the edges. Then we apply our primer to the tooth, we apply our Panavia, we air that, and then we apply our Panavia to the restoration. We take that and we light cure it after we pressed it down and held it for that time. Now if you look right here, this is the restoration cleaned up with the brush. I had finished curing it, and we're going to take the rubber dam off, and that's what it looks like immediately after cementation. The cleanup has already been done by brushing it away while I'm holding it for that first minute before I do all the light curing. So it just seems easier for me. Let's look at katana, another case. This is a case, again, we're going to go in and disassemble. Use decay indicator as I do in all the cases, so you're seeing the decay indicator here. We're under rubber dam, and now I kind of map out where do I have to remove, where am I thinner than 2 millimeters, what can I keep, what do I have to take. And it turns out in this case, because of the undermining to decay, I've got to take a fair amount, but I'm still quite high. It's just hard to see in the image. I decide to leave this area. It meets my parameters and it's not under a functional load. And I leave this contact area because, again, it's not in a functional zone. I tend to mark my preps with, I have them bite on articulating paper and grind around before I prep, so I kind of know where their functional areas are. So this is a prep we end up with. We go in and we put a little rib-on down here. We do our immediate dent and sealing. We clean up the margin if we got any bond on that. And we put our liquid lens on, and we're basically now ready to take an impression. And we are now ready to cement. It comes back, we pop a rubber dam on, we lightly air abrade, we go through all the steps that we did before. We air abrade the restoration in the lab, prime, etch the tooth, put the tooth primer on the restoration, and now we've put the Panavia into our restoration and push it down. And you can see it's all cleaned up there under the rubber dam. Now we're ready to take the rubber dam off, and that's pretty much how it looks upon rubber dam removal. So that should give you a pretty solid idea. For those of you wondering where the future lies, the Society for Cone Appearance Dentistry 2010, bioemulation with resin. Pascal Magnier and Panos Banos presented a lecture there that was pretty awesome. I've always been a big proponent of resins. I love them. This is Sculpture Fiber Core, no longer on the market, but wonderful. And so if you like resins and some of the current resins, nothing would change in all of our procedures except you would use resin as your restoration. So there you have your immediate dent and sealing. There you have a Sculpture Fiber Core restoration cemented with Panavia under the rubber dam, no different than you saw above. But there's nothing that beats the beauty of a resin when it blends in with natural tooth structure. So that concludes for today this quick overview of immediate dent and sealing, sort of modern day dentistry, and the preservation of tooth structure in the best way possible. We have a little time remaining to answer some questions. Work hard, be tough, stick to it, have the right materials, and advanced adhesive dentistry will become easy. Thanks for attending tonight.